Terrific. Hi, everybody. Pleasure to meet you all. My name is Mary Ciccarelli. I have been working at the Center for Youth and Adults with Conditions of Childhood, which we lovingly call CYACC, C-Y-A-C-C, for the last 15 years. And it is our goal to help youth and young adults as they move from a model of care that is pediatric focused into the adult model of care. So in the next 20 minutes, I hope we can talk a little bit about ways to navigate developing skills in self-advocacy and think about what core elements are necessary to a successful transition. I think it's really important to notice that I'm talking about a transition period and not a one event transfer of care. When you're a young child at 11 to 12 or a preteen at 11 to 12, you're still typically quite dependent on your family. As you move into your later teen years, you start to develop some preliminary independence. You might then actually walk across the bridge to adult care sometime between age 18 to 22. And during that period, you still tend to be a person who developmentally is leaning on the support of your family. And then hopefully at some point in our lives, be that age 25 and or older, we become an interdependent adult who uses their social supports to help them manage life, but does that predominantly in a way that is self-driven, or to use a fancier word, autonomous. And so the period of transition moves from getting onto this bridge's on-ramp in the pediatric care and being helped to develop some of the preliminary skills one needs to be able to manage one's own health care. Then you walk across this bridge and you hope you have a safe transfer of care, meaning that whoever was caring for you in the pediatric world does a warm handshake with the team that will be receiving you on the adult side. And we can think about handshakes between gastroenterology doctors or hepatologists. We can think about handshakes between primary care docs. There's lots of different handshakes that can happen in this walk across the bridge. And then as you're newly on the adult side, you have to get acclimatized or acclimated or acculturated to the difference of being an adult in charge of your own care and knowing how to navigate the different adult health system. At CYACC, we meet people who have chronic diseases like autoimmune hepatitis or have physical disabilities like spina bifida or who have intellectual disabilities like Down syndrome or have serious mental illness like schizophrenia or chronic depression. And each of those subcategories of individuals have some different needs as they're walking across the bridge I just described. What is universal to everyone is that their healthcare financing has to be sustained. The plan you have as a child might not be the plan you have as an adult. You need a primary care provider. The person who does it when you're a child may or may not be the person who's going to continue to do that when you're an adult. And you have to know enough about your own healthcare needs. Were you immunized? What's your family history, et cetera, to be able to begin to navigate your care. Now, if you're a person who has a chronic health condition like liver disease, you have to have an identification of who's actually going to be on my team in addition to a primary care provider. What is my treatment plan and how have I learned about it and how am I going to manage it? And how did I come by that education? Was it directly from my clinician, my clinical team, doctors and nurses? Was it through what my parents had already learned that they're passing over to me? Did I find other ways to educate myself? There are national experts who oversee the concept of transition in healthcare in the United States. There's a website sponsored by the Federal Maternal Child Health Bureau called the Center for Healthcare Transition Improvement. And their website is easy to remember because their logo is Got Transition. They have toolkits for youth, young adults, parents as caregivers, pediatric healthcare teams, adult healthcare teams, and teams that take care of both children and adults. And there are 6 core elements in these toolkits, and I recommend them to you. The first step is to have a policy that governs what's happening so that we standardize across patients and we treat everybody who's a young adult with equity, and everybody who's a rising adult in the adult care system with equity. And we in some way track and monitor patients on a registry so we don't lose track of them, as might happen in adolescence when adolescents are at various stages of disease acceptance and do or don't want to come to see the doctor. Then there is a step 3 is to recognize some preparation in using both assessment tools and education, and creating a formal plan of what are we going to do next so that everybody's on the same page, and then making those safe transfers of care or warm handshakes that I've already mentioned, and then actually waiting for the person to get off the off-ramp of the bridge before we say you're done. God Transition proposes this timeline for a process you might use for the walk across the bridge. And the reason you'll note that the bridge doesn't end at 18, right when a person becomes an adult, is because we in fact know that people's brains finish maturing somewhere around age 24 to 25. And behaviors we see in 18 to 22-year-olds, or abilities that we see in 18 to 22-year-olds, tend to reflect earlier adult behaviors without necessarily solid adherence or acceptance of one's own role as your own advocate in caring for yourself. So I already mentioned that the transition needs for everybody are having health care and a primary care doc, and knowing that you're going to be the person who autonomously is in charge of your own health care. When everyone comes to the doctor for teen care, we hope that we do screening to make sure their mental health is well. And we hope we teach them about puberty and about how to avoid the risks of adult life, smoking and alcohol and other substance use as common examples of risks that are available to us as adults. And then what their reproductive health issues may be as they're newly acquiring interest in that area. I gave you a very brief slide that's a Indiana specific slide, but the point of this slide is to say there's lots of different ways to sustain one's health care when you move from a pediatric to adult plan. In the state of Indiana, you're going to change from a pediatric coverage with Medicaid to adult coverage somewhere in the 18 to 19-year-old age range, depending upon which type of plan you have. You may or may not qualify for that if you don't meet the SSI definition of disability as an adult. And so you might have to use a Medicaid expansion plan or a different plan that you get through the federal exchange or through an employer or even through a college program. The main thing I wanted to say about transfers of care is that, number one, we have to identify when the change actually is happening. So it's clear when the last visit to the pediatric office is. And that is a graduation visit where things are tied up in a nice bow to be able to be ready to hand it across the street to the next bow. And then the first visit at the adult side is recognized as an introductory visit where you're introducing people to this is how adult healthcare works. And these are the things you might need to know of how to both engage our practice and take care of oneself as an adult. It's ideal or desired that there's actually a transfer of care package that moves with the person, that has a good summary and not just a photocopy of 300 pages of information that is not distillable, and that maybe has specific care plan goals of where the person and the team understand their current state of their chronic disease is. And are there emergency care issues that should be known? For example, if you're on chronic steroids, do you know what to do if in fact you suddenly couldn't take your steroids and you might have a healthcare problem from lack of steroids? All of these things should be part of what's transferred at care. And other issues that might be important is there an advanced care plan? Do you already have an identified person who would speak for you if you got too sick to speak for yourself? All of those things are things that can come with the transfer package. It's also notable that it's the sender's job to make sure there's a receiver. I like to compare this to the difference between tossing a hot potato over a fence and not knowing whether there's a person on the other side of the fence to catch it. So if you just type a letter in the electronic health record and you never know if another person gets it, that's not really a warm transfer of care. But if you talk back and forth in a communication with each other and acknowledge the receipt, then that's a true handshake. So how does one think about finding a new doctor? Well, I said everybody needed primary care, even if you have a hepatologist. And so you think about geography of where you want to go, or health system that you particularly like, or what type of adult doctor might feel like a fit for you, or a advanced practice provider, like a nurse practitioner or a physician's assistant. Does your insurance have an in-network list of who's paid through your insurance? Do you talk to other people and find out who they like and figure out what kind of personality fit matters to you? Some of us like very business-like doctors. Some of us like very colloquially friendly doctors. And those differences are choices that you might want to confer about with other people. The receiving doctor also has to have available slots to take a new patient, and you have to be able to get to that office based on its hours of operation, or how you would actually get yourself there. There's a lot of information that we could talk about, but our time is brief together in thinking about how do you build the skills to be able to speak for yourself. On the Riley Children's Hospital Kayak webpage, there's a transition book that you can look through. There's a number of these around the country from other children's hospitals. Ideally, youth begin to participate in a conversation about their health as soon as they're able. And I not so teasingly say, I start to talk to 3-year-olds about how they feel. I might not give them responsibility for making a decision at that age, but I certainly should be in the middle school and high school years involving youth in the discussion in a progressively increasing manner. Having some parents need help stepping back so the youth can step up. And so we might have to sometimes invite parents to be quiet or stay out of the room even for some portion of the visit so that the person can develop their own voice. At Kayak, we use this tool called the Transition Readiness Assessment Questionnaire, and we ask youth to fill this out and tell us, have you done any of these tasks already on your own? Are you confident in doing them? Do you need more training? And we can score this instrument. We also can target areas where the person wants to learn some new skills as an area for next step training. This is an example from Got Transition of a flow chart that a clinician might use in their medical record to help remind them where they are in the process of transitioning a specific patient. Did we already do the transition readiness assessment? Did we make a plan? Have we already created the medical summary? Did we send it to somebody already? What else are we doing in terms of prepping so this person is ready for that graduation visit? This is a tool you might use when you're already on the adult side to prep yourself to be your own voice of your healthcare. So why am I going to the doctor today? And what are my concerns? And what's happened since the last time? And are there tests I want to review? Are there medicines I need? Do I have symptoms that I want to address and create a new plan about? Using tools like this is an important way to help youth develop their voice. I also like using tools that are called stoplight action plans. And you can see from this that it's a stoplight. There's the green zone, the yellow zone, and the red zone. When one is in the green zone, you know what your body feels like when it's at its best, and you know what you are doing to maintain your body feeling well. The yellow zone is, oh, here's an alert, something's changing. Maybe I'm getting a little puffy. Maybe my skin color isn't the normal color. These are things I should notice, and I should know what I'm supposed to do about it if these things happen. Do I have to be more careful about my salt intake? Do I have to weigh myself to see if I am gaining water weight? And then the red zone would be, these are things that you definitely have to call your managing doctor about, and you should do something while you're waiting for an answer back, or get in an ambulance as is pre-described in the training. I want to recommend for you a few different transition apps. It is pretty unusual in my practice to find teens or young adults who don't have a smartphone, either Android or iPhone. And there are a number of different tools out there that you can use to help yourself walk through some of the processes I just talked about. I don't really have a favorite between these three. They're all pretty usable, they're free and user-friendly. Healthy Transitions, the Pediatric to Adult, care transition or my transition from 3 different institutions. I also tend to use a lot of health habit apps. These are when you're trying to make new habits for yourself and that are not necessarily take your medicines, but are work on healthier eating or drink more water in the day or walk more regularly, using tools that can help motivate you and record your progress so you can further progress are very useful for teens, young adults, and really anybody who likes using a smartphone in this manner. And then thirdly, another group of apps that I particularly like are ones that are specifically medication reminders. Lots of pharmacies have their own products for this. The one that is generic that I particularly like at the moment, these change over time, is called MediSafe. And you can upload the medicines you take and you get reminders from your phone and you record whether you took it or not. And it actually reminds you when it's time for refills and helps keep you on track with your management goals. I mentioned already that once you become an adult, you become your own decision maker, but particularly if you're a person who has a serious chronic disease, you might also like to have a tool that helps you identify who in your life is your backup person. That might be a parent, that might be adult sibling, it might be a partner, it might be a spouse, it might be a close friend. In Indiana, this is a new tool that's that just went live, and the law kicks into effect specifically in January of 23. But I find this tool that I've given you the link for very readable. This is the Indiana link, but the same tool is used around the country in a number of different states. I wanted to just say a little bit about how Social Security payments for disability change at age 18 to 20. Or 18 specifically. If you've had SSI before age 18 because you have a liver disease disability or another disability, you have to redetermine at age 18, and the criteria use new criteria called the adult listings as compared to the childhood listings. If you have never applied as a child, perhaps because your family's income was too high, but as an adult, you have no income yet, you may be eligible if you meet the disability criteria. Additionally, people can meet criteria by being the disabled dependent of someone who's receiving SSDI because of being retired, disabled, or deceased. In Indiana, SSI at age 18 determines whether you're eligible to stay on Medicaid for disability. In the country, receiving SSDI as an adult qualifies you for Medicare coverage after your first 2 years on SSDI. Lots of people worry that they can't work when they have a chronic serious illness. And there are many programs in Indiana too, in particular. Ticket to Work is a federal program. Indiana Medicaid MED Works is another program that helps protect your benefits, Medicare, Medicaid, or your payments from SSI while you're in fact trying out being able to be a person who works. And that happens for an extended period of time that provides support so that you can in fact step outside of your feeling that you might be trapped in your home on these benefits. That was my 20 minutes that I think I was asked to use. So this is just a slide explaining what the kayak program is. But if anyone had any questions, I'd be happy to try to entertain those.
Thank you, Dr. Ciccarelli. I really appreciate it. And such an important topic that we just don't talk about enough. And I'm going to look through the chat here, but just maybe to kick us off, as an adult hepatologist, I know I struggle with this. And locally, Dr. Molliston sends a lot of her pediatric patients to me, and I don't always know if I feel quite apt to the challenge. I do let patients and their parents kind of guide me a little bit, and I feel like I've gotten a little bit better. One piece that always still kind of baffles me a little bit is how to integrate the parents. And I know we have parents of AIH children here, and they're maybe thinking about that role. Any kind of a working strategy that you see used well from parents and how they can guide their kids into adult care? You don't automatically become capable of being a decision maker. You actually practice and acquire skill. And so if you have no opportunity to make choices and deal with the consequences of these choices, you're not going to be a confident choice maker. And so early is better. I like 3-year-olds to pick if they're wearing red or green socks today, because I don't really care which they're wearing, but they get to choose.
You might let an older child decide whether they're brushing their teeth twice a day or only once a day, etc. And for adolescents, I caution families explicitly about a process that often happens to mid to later teens where they get tired of having a chronic disease. And it's a function of being an adolescent, quite honestly. It's a function of the developing brain that makes you go, I don't really want to have this. I didn't ask for it. I hate it. I want to give it away. I'm not going to do this anymore. And it's really important that we notice that developmental stage and don't let a person come in harm's way because they have a developmental disease non-acceptance period. So parents need to be attentive to working collaboratively. I recommend parents try not to have parent to teenager adolescent fights about their diagnosis. Fight about when he gets to use the car, fight about what color her hair is. Sure, have at it. That's how one develops independence. But create a method for disease management that kind of is outside of that fray whenever possible. When a person actually reaches age 18, then there should be an ongoing negotiation of, do you need me to help? And if so, in what capacity? And how are we going to set up that plan together? And so I think I've walked through like what to do when you're 11, what to do when you're 16, and what to do with it when you're 18, as both the youth and the parent in the negotiation of working together for the same goal, which is best life.
Yeah, that's great. And what I hear, tell me if I'm wrong, but I'm seeing training wheels in my mind from the parents in a sense. And as a clinician, I also do that too. And again, there's plenty of places I'm sure I could improve. But again, I make it a point to talk to those patients if they are in my clinic, have them relay information to parents, but I also make myself available if their parents would want to ask questions and follow up too. I don't know if that's the right approach, but maybe it's one that's worked.
I think that when a person's over 18, you want their permission to talk to the parents.
Yep.
But with that permission, you shouldn't feel like you shouldn't be worried about doing it then. Should you always be discreet? Of course. I don't talk about sexual activity to parents because that's too private. And so I think that there are certainly ways to think about how to have those conversations in a way that encourages everybody forward.
I think that's great advice. And Maya has a question, which I think she has a very novel perspective as a pediatric nurse. She says, how can I bring this up with families when it's not exactly in my direct care purview?
Well, I guess it depends upon what your role is in caring for them. Ideally, on the healthcare team you're on, you should have a policy that governs the whole team. So this team takes care of children. We plan to transfer them to adult care somewhere between 18 to 22. And we try to prepare them for that. And in the preparing, you would have conversations, right? And so you would ask questions. You would suggest to your whole healthcare team that we might use a tool that helps us figure out how this kid is progressing in his skills. It is not a doctor job or a nurse job or a parent job. It's a team job. And I left the youth out and shouldn't have it. Obviously, it's a youth's job. And so I see she's adding that she's a peri-op nurse. And I think that you can, if as a nurse, you take seriously the role of being an educator, I think you can bring up the topic of, I see you're a teenager. How are you doing learning about taking care of yourself? Do you have resources to help you with that? And then you could forward them to, for example, the Riley Children's Library, the Riley Hospital Children's Library that has information on this, or websites that you might think have tools. And there would be nothing wrong with doing that as a pediatric peri-op nurse.
Yeah, no, I think that's great. And, one thing that we have at least a little bit of disease information in the research is compliance with younger onset patients and early adults as well. Is there any pieces that I should utilize from, again, your expertise in terms of when I'm dealing with compliance issues in maybe the younger patient in my adult clinic that I would do differently with maybe a 50-year-old that's non-compliant?
Well, I believe in using motivational interviewing for everybody. So those techniques transcend, honestly, the age group. We probably do it more I do it more consistently in everybody who's 18 because I presume non-adherence at 18 and I hope for adherence at 50, right? But I presume for non-adherence at 18. And so I start, how good are you taking care of your disease? I like to ask on this line of hating your disease with all your soul versus deciding that it's part of who you are and you're going to deal with it. Where are you falling right now? And youth will be very honest with me and say, I hate it way over here. And so then I say, okay, so you're dangerous to yourself right now. Let's figure out who's going to help us. Versus, I think I'm close to over here. Okay, then we can take off the scaffolding or the railings on the bridge or whatever term you want to use for that extra support because you're over here now. So that's good. But and you get to, as a young adult, accept that I'm not so good at doing this. And maybe it is a smart idea for me to ask somebody to help me. And so let's figure out who that's going to be that's going to help you. And sometimes that's a natural support in the person's family or personal community, or sometimes it's the healthcare team as a support. We're going to call you more because you have nobody to prompt you along and you know you need it. So we'll help you for a little bit. So I think that's the way to think about it on the continuum.
Yeah, no, I think that's great. My very last piece to that is, again, I haven't taken many children into adult care, but there has been at least one instance and maybe two where I thought it was inappropriate for them to come to adult care. As a clinician, I'd be interested in your opinion. Is there any way I can call up Dr. Molliston and tell her, gee, I just don't think that this kid and parent is ready for adult level care, and maybe there are better resources at least at the pediatric institution?
Well, there's an interesting problem in that physiologically one's body ages and pediatricians are good at taking care of younger bodies. And by their own choice, they're not good at pulmonary embolisms, strokes, and heart attacks. That's just not in their usual scope, right? And so they're not good at reproductive health care, and right. And so I think that everybody needs an adult doc, but might need a hybrid. Maybe they need a primary care doc who's good at both children and adults, so that person can handle the person because they have developmental issues, or maybe because their size is smaller than a usual adult size, we have to do some different work in figuring out what size scope even fits this kid. So it depends. I think once you get beyond age 25, one should question whether a pediatrician should be caring for that age person.
Yeah, no, that makes sense. I know Alyssa here left a comment. Was there any other, and I think it was interesting. Was there any other questions or comments for Dr. Ciccarelli? Dr. Ciccarelli, I want to just again extend a tremendous thank you for lending some light into this really important topic. Again, this affects a small portion of our rare patients, but it is an incredibly important one and often overlooked. So I truly am grateful for your time and your expertise. Thanks again for joining.
And I want to second whoever said that Wordle's word of the day today was liver.
Fair enough.
I think somebody on this call must have made that happen, and I find it amusing.
It's a sign. It's a sign.
All right. Nice to meet you
Thank you so
all.
much.
All right. Bye-bye.